Hello, everyone. I'm Dr. Brian Loyd. I'm in from the University of Utah. I'm a PT, and I did a lot of my PhD work in this area, specifically in total knee. So I always like to start with a joke. I know there's a mix of people in here: orthopedic surgeons, PTs, PAs, nursing maybe, and so. I think this kind of holds true across how we manage people after TKA. Obviously, there's a lot of things going on, but what we tell patients as far as swelling is concerned is quite varied, and I think it, in a lot of cases, lacks substance. So we know that swelling is a natural phenomenon that occurs after the surgery. It'd be actually probably more surprising if a person didn't experience any swelling after the surgery. And it's kind of a combination of things that are going on. And we don't really have time to get into all of that, but the tissue injury that occurs at the skin, soft tissue, and the bone itself results in a cascade of inflammatory inflammation that ultimately results in swelling, which swelling is kind of a term that we're using to account for both edema and effusion. Data would suggest that we know patients are going to have swelling for at least 2 to 3 weeks, and more recent data says the swelling can last 3 to 6 months. I think anecdotally, depending on the patient, that can actually be much longer. So I want to talk a little bit, I think this is kind of why I'm really here, is to talk about what the impact of that swelling is. So what we know is after surgery, people experience massive declines in the quadriceps strength after total knee replacement. We see a lot of this in total hip as well, and I'm sure across a lot of lower extremity trauma. But after TKA, we know it's on the order of 50 to 60% within 1 month after surgery. That's enormous. So it has huge implications for function, just moving the limb and healing really as a whole. And this is primarily related to this idea of arthrogenic muscle inhibition. And so that's caused, again, by a lot of factors. However, there's some data to suggest that swelling plays a big role in that. And without getting into a ton of detail about what that looks like, in the presence of edema and increased swelling, we alter firing from peripheral receptors across various types, but then they ultimately loop back to the spinal cord and cause inhibition of the excitability of those motor neurons. And I'd be happy to kind of talk about that if anybody wants to afterwards. But it's oftentimes contributed to pain. And while I'm not saying that pain plays a role in arthrogenic muscle inhibition, it's not the only factor. And there's some evidence that points to the role swelling is playing in this. And this is kind of a good example of that. Now, this isn't in a true patient population, but what we see here in this this study from, I think it's 2004, what they did is infuse the knee. Some of you have probably seen this data before, but what they did was they one group of patients where people was infused like a 30 milliliter infusion into the knee joint capsule, but both groups were numbed, so they weren't able to sense anything. Pain was not driving this, and what we see is this immediate decline in activation of the quadriceps. So while this isn't exactly like the swelling you see after a total joint or trauma or anything like that, it really kind of gets to the idea that pain isn't the only driver, and swelling really is playing a role in this. So the other big thing I want to talk about is like what I consider to be the 4 challenges surrounding the management of swelling, and I kind of want to charge all of you to chime in on this as we go. So the first question that really kind of drove my work is how do we accurately, reliably, and reasonably being key here, measure swelling after TKA or lower extremity trauma? And you all might have thoughts on that. I'm going to talk about some other things as well. So how does everyone here measure swelling? What's that? Tape measure, right? Yeah, so tape measure is the most common answer. And there's nothing wrong with that. I think that's better than not giving an attempt at all, because a lot of people are just like, well, that looks swollen. Good luck. Tape measure, unfortunately, and some of my data found that it's just highly unreliable, unfortunately. So inter-rater reliability between me and any one of you is very low when using a tape measure. And then over time, it oftentimes is poor as well. So we need to get better at this. There's a variety of ways to do it, but it's not really the point of the talk today. So I challenge people to, one, measure it better. The second big thing is, what do we expect for outcomes after surgery? So I kind of stated earlier that on that 6-month scale, are people seeing swelling for 6 months? Are they seeing swelling for a year? Like, what are we telling patients as far as what they should expect the length of their swelling to be?
I generally say like 6 to 8 weeks, and at 3 months we start seeing marked improvement.
Okay, and that's actually that's probably likely a case for a lot of people. However, unfortunately, maybe not for everyone, right? So some of the work I also did was to kind of create centile reference charts for what swelling should look like after surgery, so that we don't rely purely on the mean, because what we know is the mean only captures those people right around the 50th percentile. There's people a lot better than that. There's people a lot worse. And what we found is even 7 weeks after surgery, the 50th percentile of people are still demonstrating on the order of 20 to 30% increased swelling above what they were at baseline or before surgery. So again, I know I'm only in a TKA model here for those of you who aren't in TKA, but the fact being that swelling is lasting, it's occurring in everyone. We're seeing this marked increase 6 days after surgery on the order of 30 to 40 to 50 to even some of our people higher than that percentage increase from what they were before surgery. And so what we found, again, coming back to looking at the amount of swelling after surgery, this is kind of what I was just saying, is what we found was swelling was peaking for most of these people after TKA at about 6 to 8 days post-surgery. And that's important because we think it affects their downstream outcomes. So again, question is, do we think that swelling is going to have an effect on people's strength, on their function, on their pain, on their range of motion? Variety of outcomes. And so the data suggests, and when I say the data, there's not a ton, probably that I'm aware of, 3 or 4 studies that have really looked at the influence of swelling itself or edema on strength and function after total joint replacement, after total knee. And this study was one of the first that found that swelling was in fact related to greater swelling resulted in decreased quadriceps strength after TKA. And then those same people who had weaker quadriceps had much lower walking speed. So not as only affecting the function of their quadriceps, but ultimately resulting in decreased daily activity or functional performance as indicated by walking speed. A more recent study found very similar and more sophisticated study, I will say, found very similar results. So as knee swelling increased across this population of 85 people after TKA, this marked decrease in quadriceps strength was observed. Furthermore, that swelling, when controlling for certain covariates, contributed to decreased fast gait walking speed. So again, showing that clear line of relationship between swelling of the lower extremity, quadriceps weakness, and ultimately function. And lastly, I toot my own horn a little bit. So some of the data that we published was looking at the timed up and go test. If there's PTs in the audience, you're certainly aware of this, and I'm sure any healthcare provider really is. But it's a good measure of function that includes standing, walking, turning, returning to the chair. Swelling was a strong predictor of the function on the timed up and go test 2 weeks after surgery in our sample. So just to kind of really sell home the point that we think that the swelling is playing a critical role in not only strength and pain, and while I don't have data specifically looking at pain, but functional performance. And we know that all these things can ultimately result in longer term effects. You know, some of this data some of these things are still in need of being studied, but we know that if your function declines, especially in an older population, we see this increased risk in mortality and loss of independence and social isolation, things of that nature. So the last thing I want to talk about, how do we effectively manage swelling? So the last kind of question I'll pose to you all is, how are you managing swelling in your patients? Yeah, okay. So cryocuff or something like that, right? So commonly we see the old adage price, right? Elevate it, ice it, compression if you can. And it's really been in existence for a very long time in how we manage orthopedic injuries. You might see something more like the pneumatic compression worn by the woman on the right, cryocuff, something of that nature. Unfortunately, without getting into it, these methods are potentially outdated and they're potentially not really getting at the root cause, and they have a lot of issues, right? As a PT, I'm all about function and the ability to get up, be active. We know that helps reduce swelling. So to kind of finish up what I was going to say today is what device is going to allow us to hopefully manage swelling, but allow for functional independence, ability to be up if possible, not tie you to the bed, and be more effective than a simple, price or rice technique. Okay, and that's kind of lead into where we think the gecko fits into this.